have a depth now. Dr. Moazen, please.
I have to see.
So Dr. Boniolo, I really enjoyed your talk. Now, I just have one question for you. I agree with you, what you say, and we have to bring back the PH into the PhD. I agree with that, but that's kind of something, whether we have personalized medicine or not, that's a very basic thing. And I agree with you 100%, but I'm just kind of curious. Do you think that's necessary for personalized medicine, or it's just something that all of us should be working at?
Of the best book that first time draw the difference between the clinical medicine and the experimental medicine was written in 1844 by Claude Bernard, a Greek physiologist who worked on diabetes. And Claude Bernard was an example of the way in which the scientists of that age were really involved in questions concerning what I'm doing. I'm doing just research in order to obtain data, in order to publish, in order to have more and more academic power, or I'm doing something which is worth for the humanity, for the mankind. And the same did Henri Poincaré, Meyerson, Bridgman, Enriquez, Mach, Boltzmann, Hertz, Florensky. This is something that should be applied in any field of science. But in particular now in precision medicine, because precision medicine has a lot of impact on the society, more than quantum gravity. Who cares about quantum gravity? But we care a lot about precision medicine, because precision medicine is changing our life. So in Europe it's changing our life. And so this is something that we should fight for.
Just a short comment. As the only person here with no PhD, you really challenge me. I don't have a PH to enforce. I'm the only one here, I think, without a PhD. So all sorts of ways to cut populations and personalized treatment.
You know, it is possible to have something this in a medical school. You can fight in order to have a bunch of hours that allow you to expose the students to these problems.
Dr. Cohen.
First of all, thank you. I think the combination of a smart and funny talk with the Italian cadence is just so fun. I can listen to it forever. I'm wondering whether you have any thoughts about how to reconcile the goodness in medicine moving more towards wellness with a way of not creating the problem of patients in waiting, in the sense that, you know, we'll be just in an endless rat race of so many parameters that could be better. Is there a way to integrate wellness without creating this problem that you call patients in waiting?
You are perfectly right. And an answer was given at the beginning of the 20th century by Max Weber, when he wrote that those who eat the fruit of knowledge has also to take the responsibility of having eaten the fruit of knowledge. So there is no possibility to come back. Now we have patient in waiting, and we'll have patient in waiting. The problem is to manage the patient in waiting and to give them the possibility to be patient in waiting or not to be patient in waiting. That is, there is the duty to inform, but not the right to be informed. So one can avoid. But not only there are the patient in waiting, there is also the would-be patients. That is, we have a sequence and we have a certain mutation, and that we do not know if that mutation is lethal, is neutral, or carry a sort of benefit. So we do not have the patient in waiting only, but we have the would-be patient. We have to manage.
Dr. Perlmutter.
I hate to say it, but with respect to all of us in this room, it's not going to end well. So we are all patients in waiting. It's just a matter of time. So just to be clear, that all we're saying is, and there used to be an analysis of this that people would say, sort of in a biochemical kind of way, if we know trait, that you have trait, then we're interested in state, what is your current state of being, which is sort of the wellness argument that Lee does. And then we want to understand the rate at which you are progressing, right, that might be defined by that trait. It could be a very slow rate, or it could be relatively rapid, and that might demand intervention or not, which is only a way of saying, gosh, we'd like to be thoughtful about this knowledge, but we can't avoid biting the apple. We really need to understand those things, because ultimately we have to have a way of interpreting when it's appropriate to intervene and what sorts of interventions might be correct. Now, to the public health argument, I mean, there's a generality of sort of public health interventions that we think about. Low-cost interventions, often performed early, in many cases with individuals who are patients in waiting, as we all are, and we imagine that it prevents something from happening. So normal people in whom we prevent a disease entity from taking place. What we have to recognize is two issues, James, to think about. And your talk is terrific, and I think you're quite comprehensive, but just want to make sure you capture two ideas, and maybe you did already. The first is that with precision medicine for individuals who already are identified as diseased, and we say, well, some people really show no chance of benefiting, so we won't administer this drug. And you say, well, there are three possibilities. One might be that actually they're harmed by the drug. The other might be that it doesn't matter one way or the other. And the other is that they might actually benefit even though you didn't think they would. The real case, I think, is it's unlikely that they would not be harmed, because there are two potential causes of harm. The first is all drugs have adverse experiences. They're likely to experience one. The second is, by virtue of the fact you administer a drug, there's an opportunity cost. They can't get something else. And we have already provided data that says this particular drug doesn't work in that population. We don't know about the experimental ones, but we deprive them the opportunity of getting that one because we give them something that we already know doesn't work. So they're harmed in that sense because of the opportunity cost. And I think it's important to capture that. The second issue that I would address to you is the issue of mass administration in the public health context of true interventions. Let's think about immunization. And there's the very real-world case of pneumococcal vaccines. So pneumococcal conjugate vaccines administered broadly to the neonatal population because of the higher susceptibility of the young population to invasive pneumococcal disease. What happens, though, over time is that you mold the environment of pneumococci, and that changes the appearance of the pneumococcal strains decades later in the adult population. So that's not to say that mass vaccination is a bad thing, but one has to be cognizant of what you're going to be treating sometime later. It's a little bit like Eric Lander's point about managing over time, over a period of many, many decades, and I think important to think about.
I wish to, you want to answer? Just very briefly, Professor Nicole and Professor Erdon.
Thank you. So I've really enjoyed your presentation and all the talks today, but one of the things that keeps striking me is how much expectation we're putting on the family doctor, the general practitioner who sits at that interface, who's the key to the doctor-patient trust relationship, key to the care relationship, and so on. And certainly in my country, we're thinking about how we actually prepare those general practitioners for what's going to come? And are we actually putting too much expectation on the GP in rural Tasmania or in the middle of Pakistan or wherever they may be? How do we help them through this?
I want to tell you a story that happened in our hospital. And there was a lady, 35. She had 2 children, 3 and 5, and she had breast cancer. And she had surgical, chemotherapy, so on and so forth. And then she told that also her mother had a certain kind of cancer, the uncle, and so on and so forth. She was tested by P53. And all the family was tested, and at the end, the outcome was Li-Fraumeni syndrome. She asked to the family doctor that also the children, 3 and 5, had the possibility to be tested. In order, and here the problem begins. This is not a fake problem. This is not an abstract problem. This is not a philosophical problem. This is a real problem that we have to manage. Should we give her the permission to test the children? If the answer is negative, wonderful. But if the answer is positive, at which age we tell the children that they could be potential, they could have potentially a cancer? At what age? At 3, 5, 18, never? And this is something that we have to manage. And we have to prepare the general doctors to manage this kind of problems. Who cares about a flu now? We can check the solution online. I take an aspirin. But this kind of problem are humanistic problems, are existential problems. These are no more clinical problems. And there are an increasing number of clinical decisions that could be taken after that an existential or ethical decision has been taken. And this is a wonderful example of this. So something has to change. When Shlomo spoke about that precision medicine is changing the structure, the setting up of the Earth system, it's true. But not in the future, now. Because now we have this kind of problem. All of us, as correctly Roger said, we are patient in waiting. We do not know how long we wait for.
I'm on time. Yeah, well, maybe I won't say anything. Having worked particularly on questions of race and genomics over many years, my concern would be if we tell people we tested this population, we found out that you actually aren't going to benefit, I'd be really worried about how the population got defined. You better do those studies correctly. And at this point, I would not be willing to trust it. So I'd say, give me the drug. Anyway, that's just me taking, I'd be willing to take the risk. So the other thing, quickly, you might not need a doctor if you have an app, and that's increasingly where people are going with genetic information, which raises the question of when you get the app. So with breast cancer testing, there's my university designed an app you can put on your phone. So, there's 10,000, there's thousands of variants. It's a big piece of real estate, BRCA 1 and 2. So you might want to freeze your embryos, and then you're 20, and then, over the next 10 years, research will be done, and then you'll get a little, notification every time a genetic variant you have, they got some more information on it. Either it puts you at risk for breast cancer or it doesn't. This is the idea. I haven't talked to any woman who wants this app on her phone. But anyway, the question of how people are going to get this information and when and from whom is a big question.
I think we can go to the break now. And
Sharp on time.
yes, at 10 to 5.